Welcome to a Puscast. This is the Puscast that will cover with the first 2 weeks of April 2013. This is copyright 2013 by edgydoc.com and Mark Crislip, MD. And let's get right to the infantile podcast, shall we? Why infantile, you ask? Did you know that there's a fructose gene in organisms and you can use a PCR to diagnose Haemophilus influenza? The article is Quantitative FUC Big K Gene, Polymerase Chain Reaction on Sputum and Nasopharyngeal Secretions to Detect Haemophilus Influenza Pneumoniae. Not only is there a gene for that, but there's also a whole series of fuck genes. There's the fuck I, there's the fuck C, there's the fuck U, and the fuck R. And I just am such a child. That's how fructose is metabolized. Sorry. Oh, God. So, let's get to the real stuff. It just shows you that you can be only young once, but you can be immature all your life. There was an article that looked at the efficacy of copper in the ICU to prevent infections. They had rooms where all the surfaces, including the IV poles, were copper. I assume this was done in an area without a lot of lightning. And they compared the infection rates in the copper rooms versus the non-copper rooms. And they decreased the infection rates in the rooms with copper to 7.5%. That means that 1 in 13 patients in their ICUs were getting infected. That is a hospital you do not want to be admitted to. One of the problems with all these studies that show a decrease in infections is they usually go from horrifically awful to awfully horrific. I mean, 1 in 13 infection rate is pretty appalling, and you got to be wondering what they're doing with the basics of hand hygiene and proper isolation techniques. None of my ICUs have anywhere near that kind of infection rate. So I never really know how to interpret these studies. Some good news, bad news in the HIV world. Let's start with the good news. It appears that resistance in HIV has been declining in Western Europe. It's gone from 80% of cases with at least one resistance gene in 1997 to 71%, and 3-class resistance peaked at 4.5% and is now going down as well. So there is, curiously, less resistance to HIV than there has been in the past to antiretroviral drugs. Why that is was not discussed in the article. The bad news? Well, turns out, and this is an important article for those of you in the Navy, but they compared standard heart to intensified heart. Intensified heart is the addition of ratigrapir or Maraviroc, which sounds like a end of the world. No, that's Ragnarok. Well, there's all sorts of ends of the world. HIV isn't one of them. But they pick these medications because they have high levels of concentration in semen. So they compared HIV levels in semen in patients on heart and intensified heart and found although there was a transient reduction of HIV in semen, it was not complete. And they could still find HIV so that it could potentially be transmitted. Unfortunately, even when you have no viral load in the blood, you can still have detectable virus in semen, and there have been transmissions. So that was kind of a bummer. Whether this is the same in the Army, the Navy, or the Marines has yet to be elucidated. Oh, wrong kind of semen. Sorry. That's my Emily Latella joke for this podcast. And finally, in the general population, what's the carriage rate of MRSA? Well, it depends upon the population studied. It can be as low as 0.8% in a completely general population. It's running about 4% in patients admitted to ICUs at my hospital. And in this study, which looked at MRSA colonization in HIV patients, they found that 20%, 1 in 5, had MRSA. Interestingly, in their control population, that rate was 11%, of HIV negative patients. I hate the flu vaccine, mostly because it's such a lousy vaccine against such a virulent bug. This study looked at the effectiveness of the prior year's H1N1 vaccine for preventing flu in subsequent years, because the H1N1 of 2009 did not exhibit any antigenic shift between one season and the next. So they looked at the efficacy of the flu vaccine year one. It was about 63%. And then they looked at it the next year, minus 1%. That's what it says in the abstract. The article itself says it's about 0%. This is interesting and reinforces the need to get vaccinated every year for flu. Although, as is always the case, nothing in medicine is clear-cut, since there was data to suggest that receiving the flu vaccine in 1976 protected you against the 2009 H1N1. So it always depends, doesn't it? And then there's H7N9, the new bird flu in China. It's killing about 20% of the people who get it. So far, the majority have had exposure to chickens, where, according to the New England Journal of Medicine review, the organism is genetically predisposed to cause widespread, fairly mild disease in chickens and the like, but likely to infect humans or other mammals, where it's killing, as I say, about 1 in 20. So this does have some potential for becoming a pandemic strain, and there's some data now out to suggest that there is some human-to-human spread. So conceivably, it could spread around the world in birds, causing mild illness, and then jumping to humans to cause more severe illness. Will this be like a 1919 pandemic? I don't think so, but flu always makes you nervous. I don't normally talk about kids-related illnesses. I'm an adult infectious disease doctor who I treat, not necessarily how I act. This study looked at the effectiveness of the varicella vaccine over 14 years and found that its efficacy did not fade, which is nice, because also this week was a report of a teenager who got chicken pox and died. She had no underlying medical problems and had progressive varicella complicated by multiple bacterial infections and death. The reason she didn't get her vaccine was she was a little older and was not part of the routine vaccination cohort and never had a, quote, catch-up, end quote, of her vaccinations. Like many of the cases who die of varicella, there have been about 112 such deaths between 2002 and 2007. The majority had no pre-existing reasons for getting severe varicella, i.e. cancer, immunodeficiency, or pregnancy. Death is fortunately rare from the childhood illnesses, but it does occur occasionally, and occasionally people who are not vaccinated will become extraordinarily unlucky and die. It's sad. The vaccine's good in kids, and it's good in the elderly. In this study in PLOS Medicine, they looked at the efficacy of the vaccine, and it cut zoster rates by half. It went from 10 per 1,000 person years in the unvaccinated group to 5.4 in the vaccinated group. But more importantly, it protected against post-herpetic neuralgia. Zoster ain't so bad. I had zoster once upon a time, but it was painless. What makes people absolutely miserable is the post-herpetic neuralgia, and it's more common in the elderly. And it cuts the rates of post-herpetic neuralgia by a little bit less than half compared to unvaccinated. Not bad. VZV is also not an uncommon cause of encephalitis/meningitis. In this study in Switzerland, they had 519 spinal fluid specimens who had either viral meningitis or encephalitis, and 11, or 2%, had VZV. And not everybody had classic zoster when it happened. Patients with encephalitis did poorly, as patients with encephalitis are wont to do. But consider VZV as an etiology of your encephalitis or meningitis. Although one would always wonder, in something that lives in the the dorsal root ganglia, the dorsal root ganglia of the spinal column, that if you get a little bit of CSF irritation due to aseptic meningitis, that you get reactivation that isn't actually due to the virus. But still, 2.1% is not a bad catch for viral meningitis. And finally, I think this is very interesting. They looked at patients who were depressed who got the zoster vaccine, and they didn't respond as well by lab parameters as patients who were normal controls, and that when you treated their depression, their response to the zoster vaccine improved. Ooh, mind-body connection. But it is interesting that depressed people are immunosuppressed in some mild way that prevents them responding to at least VZV and perhaps other vaccines as well. So I was asked today on rounds, should I be worried about a patient who has 40% bands but a normal white count? I'm on call this weekend, and wouldn't you know it, there was an article that addressed this very topic. One of the spooky things about doing this podcast is how often things I read about show up in the next couple of days or weeks. So this was from the American Journal of Medicine, and they looked at the significance of bandemia in patients with infection who had otherwise normal white counts. They called it normal if they had less than 10% bands, moderate bandemia if it was 11 to 19% bands, and high if it was greater than or equal to 20% bands. And they found it was a bad thing. Patients who had moderate and high bandemia on admission were more likely to have positive cultures, including blood cultures, and had a higher in-hospital mortality. So beware the bands. Though I've never liked the term bandemia. Bandiosity? I think that's a better term. Consider it copyrighted. Mark Crislip, 2013. You might remember the huge outbreak of Shiga toxin-producing E. coli in Europe. One of the questions that always comes up is, how long do people excrete pathogens? And they looked in this series of 321 patients and saw how long it took for them to no longer shed their Shiga toxin-producing E. coli in O104H4. And the median was about a month, though some went on for several months. Whether that's applicable to all enterohemorrhagic E. coli or not, I do not know. But I wouldn't let them prepare my salads for at least a couple months after they had an illness. I have written about raw milk over at Science-Based Medicine. I'm always of a mind that if you look at a cow, you see butt, then you see 2 feet below that, under the flow of gravity, udder. It's not surprising that you can get a GI pathogen from raw milk. I always consider the human orifices to be like those maps they used to show of what would happen if you have a nuclear weapon dropped on Boston. You get the blast zone and the fire zone and the radiation zone, these decreasing zones of damage from the bomb. I think each orifice in your body is similar declining incidence of bacteria as you get further and further away. The bugs don't stop at your butt, nor the cows. And they pointed out that there were 2 outbreaks of Campylobacter associated with raw milk, and the rest in Germany with this study were from handling chicken. But raw milk contains diseases. There's pasteurization, which was one of the great inventions of all time. Some people think ruins the taste of milk and ruins its health benefits. I don't think either are true, and I think Campylobacter diarrhea tastes worse, metaphorically speaking. I'm not a pulmonologist, and I don't play one on television, so I'm not certain if this represents a real important breakthrough. Patients with bronchiectasis who didn't have cystic fibrosis were randomized to either erythromycin or placebo, and there was some modest benefit, as they say in the article, from those who received erythromycin. What is modest? Well, the placebo group had 1.97 exacerbations a year versus 1.29 in the erythromycin group. The sputum went down by 4.3 grams. That's not a lot of sputum difference in a 24-hour period. And there was a decrease in the decline of lung function of about 2.2%. Not really dramatic. One would wonder if this made any real difference in the patient's quality of life. As a result, however, there was increase in macrolide-resistant streptococci in those that were on erythromycin. But I will defer to my pulmonary colleagues as to whether the bang is worth the buck in giving bronchiectasis patients erythromycin. I keep harping on this one thing. Infections are bad for you. You get an infection, you get inflammatory. You get inflammatory, it's prothrombotic. And if you get prothrombotic, you get more vascular events and die. Now, every infection out there has increased mortality rates and or increased in vascular events after the infection. The Annals article showed that flossing your teeth gives you an increased risk of a TIA if you're elderly. This study looked at long-term survival following pneumococcal pneumonia and found that mortalities increased up to 10 years after getting pneumococcal pneumonia, although they do not look at, again, why people died. I wonder how many of these are vascular deaths. Now, it's been known for 100 years, maybe a little less, maybe a little more, that getting an acute bacterial pneumonia, pneumococcal pneumonia, increases your rates of myocardial infarction and it increases your risk of arrhythmias. And here is the cool article. They randomized patients to aspirin to BID for a month versus placebo after coming in with pneumonia. And patients who got aspirin had a decrease in acute coronary syndromes and cardiovascular mortality. Someone's finally done the study. If you take aspirin during your pneumonia, you're less likely to die, or at least less likely to get a heart attack, which makes you more likely to die if you have a heart attack in the next year or 2 or 3. Heart attacks are bad for you. Infections are bad. Thrombosis is bad. The two go together like peanut butter and jelly. And here's the first study that shows an intervention is beneficial. Ooh, I'm getting excited. My time at Science-Based Medicine has not made me a fan of the Cochrane reviews. So even when they do a respectable one, as opposed to the one where they did a meta-analysis of acupuncture for mumps and did a review of one article, this is on the use of osmotic therapies for meningitis. Because you're always trying to prevent brain damage, and perhaps if you give them an osmotic agent, they will have less brain edema and therefore less problems and death. They did their usual search and did not find much of great effect. The best they can say is that maybe they decrease deafness, doesn't alter mortality, and the data, as is always the case for the Cochrane review, is low quality. The best they can say is that they do not recommend that these agents be used outside of, quote, carefully conducted randomized controlled trials, end of quote, which is always a problem when you have someone trying to die of bacterial meningitis. It's sometimes hard not to give therapies that may be of benefit. Normally, when treating prosthetic hip infections, you take them out, you give them a course of antibiotics, you stop. If there's no further signs of infection, by tap or intraoperatively, you stick a new hip in and hope for the best. It usually works. This study, however, at the time of hip reimplantation, patients are randomized to either get placebo or a minimum of 2 weeks of oral antibiotics postoperatively. They had no infections in the oral antibiotic group compared to 13% in those in the placebo group, which is pretty impressive. This is one study and needs to be repeated, but it is most curious, and given the morbidity associated with prosthetic hip infections, and as much as I hate to do practice based on a single trial, I'm strongly tempted to try this in my patients. I've always been of the opinion that the cryptococcal meningitis papers over the years have been papers on how you can badly treat cryptococcal meningitis. For example, the original New England Journal studies that compared amphotericin plus 5-flucytosine or amphotericin without 5-flucytosine that showed a benefit of 5-flucytosine addition used piddly doses of amphotericin B, like 0.3 or 0.4 milligrams per kilogram. And the problem with all these studies is they use an endpoint of time rather than cure, which will work some of the time, but seriously, you don't stop therapy just because of an arbitrary endpoint by time when you're treating a fungal meningitis. You should aim for cure, however you best try to define that. And as the years go on, they have published other studies that have decided, how can we minimize our efficacy and maximize our morbidity in treating cryptococcal meningitis? This study was out of Vietnam and published in the New England Journal of Medicine. And they compared patients who received either AMPHO with 5-FC, AMPHO without 5-FC, or AMPHO plus fluconazole, and found a benefit in the patients who got AMPHO plus 5-flucytosine. Again, the problem, they gave a defined course of therapy rather than curing the patient or treating them to an endpoint where you think that the patient is clinically resolved. And they did use a good dose of AMPHO, 1 milligram per kilogram, which is better. When it comes to treating cryptococcal meningitis with amphotericin, more is better. And then, as best I can tell, they sent everybody home on a defined duration of fluconazole. And as best I can tell from the study, stopped it cold. And unsurprisingly, they had lots of deaths at the 182 mark. 53 out of 99 in the AMPHO group, 34 out of 100 in the AMPHO plus 5-flucytosine group, and 45 out of 99 in the AMPHO plus fluconazole group. One would wonder if they had, as best I can tell, continued their fluconazole, they would have done better. But it's a third or second world country, so they don't have the resources of other second and third world healthcare systems like the United States to continue the medications longer. But the take-home is AMPHO high dose plus 5-flucytosine should be the treatment of choice up front for cryptococcal meningitis. And when to start highly active antiretroviral therapy in, or as they call it these days, ART, active retroviral therapy in AIDS patients with cryptococcal meningitis is unknown. This study out of Philadelphia randomized patients to early ART, 7 days, or late ART, 32 days. There was no improvement in the resolution of the cryptococcal meningitis, but those of whom had it early had immune reconstitution syndrome, about half. 2 of them died of their iris-related cryptococcal flare. So the take-home is if you have a cryptococcal meningitis in a ART-naive patient, you should wait a while before instituting the ART. But how long? A couple weeks? A month? Unknown. However, a month would seem reasonable. For those of you who are fans of meta-analysis and evidence-based guidelines, the American Academy of Neurology has released guidelines for the treatment of my favorite nun, Sister Cirrhosis, and they recommend albendazole in favor of praziquantel and steroids. How long to give the steroids, how long to give the albendazole, whether you can give steroids alone, etc., are not known. And finally, strongyloidiasis that was spread to 4 transplant patients by way of organ donation. Definitely an unusual way to get strongyloidiasis. 2 of whom died, 1 of whom probably died of the strongyloidiasis. So, something to think about with organ transplants. That brings us to the end. For those of you who like reviews of topics, the New England Journal of Medicine has a nice one on endocarditis this month. But otherwise, that brings us to the end of this Puscast, a review of the infectious disease literature covering the first 2 weeks of April 2013. References are available online. Visit my website, edgy.com, for my growing multimedia empire of podcasts, books, iPhone apps, and blogs. Because the world needs more. Mark Crislip. Otherwise, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you, in dictation. Goodbye.